And I say I'm a non-believer because I think that we've gone overboard about the concept of the role of vitamin D in health. There are the believers and the non-believers. I think Professor Kruger is a believer. She was talking about vitamin D status of levels of 70, etc. and above. I must admit I don't think we've got evidence to substantiate levels that high at the moment. So what I wanted to talk about today is in fact exactly that. Some idea of what is the role of vitamin D in health. And I'm going to talk to a certain extent about bone health, but there are many other areas that are also important. This is one such advert for vitamin D. One of the most powerful healing chemicals in your body. Now, I mean, you'd all go out and rush out and buy enormous doses of vitamin D. Even in South Africa, even in Gauteng, even in Johannesburg, where we have adequate sunshine basically throughout the year. The classic role of vitamin D is, I think, the role that you all know about, and it's the role of vitamin D in bone health, as Professor Kruger has mentioned. And it's vitamin D obtained mainly from sunshine, being converted in the body to 25-hydroxyvitamin D in the liver, which is the major circulating form of the vitamin D, and then to the kidney, where it's converted to 1,25-dihydroxyvitamin D. And the major role of vitamin D in the system is to, in fact, improve calcium absorption. That's its major role. You don't need vitamin D to prevent the development of rickets. You need vitamin D to optimize calcium absorption so you have adequate calcium and phosphate levels to mineralize bone. But vitamin D plays minimal role in actual bone metabolism per se. So this is the major function. It is important in ensuring that we have adequate absorption of dietary calcium to increase serum calcium levels and maintain normal calcium homeostasis so we can actually mineralize the bone that we have. Now, vitamin D travels in the circulation attached to the vitamin D binding protein. And here we see the vitamin D binding protein as the little square box, and the vitamin D attached to it. It enters the cell, this is 25-hydroxyvitamin D, the major circulating form, enters the cell, or 1,25-dihydroxyvitamin D, enters the cell, losing the vitamin D binding protein and binding to the vitamin D receptor, which is absolutely essential. You have to attach the 1,25-dihydroxyvitamin D to the vitamin D receptor, and then it then attaches to the genome and produces the effects of vitamin D in the nucleus of that cell, producing various proteins particularly. So there really are two processes. There's the conversion of vitamin D from vitamin D itself to 25-hydroxyvitamin D, and then 1,25-dihydroxyvitamin D, and that then enters the cell via the vitamin D binding protein and into the vitamin D receptor, and the vitamin D receptor with 125 then attaches to the genome at the vitamin D regulating elements in the chromosome. Now, if we look at the whole issue of vitamin D physiology, what we've been talking about is this role up here, this, if you like to consider it a triangle or an iceberg. There is the well-known action of vitamin D, which is related to the vitamin D receptor producing an increase in calcium absorption particularly, and ensuring bone mineralization and ensuring the prevention of osteoporosis. That was one of the conditions that Professor Kruger mentioned. But there are many other activities of vitamin D. The first is the effect of vitamin D in cells locally. So it's a paracrine effect of vitamin D. And the effect of these are on immunomodulation, antimicrobial activities, detoxification, anti-cancer effects, skin integrity, and beta oxidation. And this is the effect of vitamin D stimulation within the cell having a direct effect on various chromosomes within the cell, genes within the cell. There's also an effect on hair cycling and hair development. You don't need vitamin D for normal hair development, but you need the vitamin D receptor for normal hair development. And children who have genetic abnormalities of the vitamin D receptor have total alopecia. So they're completely bald, no eyebrows, no nothing. Not because they are missing vitamin D, but because they have the abnormality in the vitamin D receptor. And then there are other activities of vitamin D which relate to detoxification, cell differentiation, antiproliferation, apoptosis, cardiovascular benefits, and anti-inflammatory effects. So there are a broad range of activities that may have an effect, may be influenced by vitamin D. So if we now look at the roles of vitamin D, there are two very different functions of vitamin D and physiology of vitamin D. There's the role that we understand, the endocrine functions of vitamin D, which is the control of calcium homeostasis and bone mineralization, where one goes through vitamin D to 25-hydroxyvitamin D and then to the liver, where you form 1,25-dihydroxyvitamin D. And this is then transported, particularly to gut cells, where it has the effect on calcium absorption. There is, however, another function of vitamin D, or possible function of vitamin D, and that is the paracrine or autocrine effects of vitamin D, where 25-hydroxyvitamin D enters the cell as 25-hydroxyvitamin D, and it's within the cell that that particular cell actually has the enzyme necessary to convert 25 to 125. And the 125 produced by that, in that cell, has a direct effect on the gene within that cell and produces a product, a protein. Or it is excreted or secreted into the peripheral cell, into the cells around that particular cell in a paracrine effect, and has effect on other cells very closely linked to this particular cell. And that is what has excited people over the last particularly 20 years. And it's why there has been this discussion about what should our vitamin D status be? What should our normal levels of vitamin D be? If we look, for instance, at the relationship of vitamin D, calcium, and vitamin A, for instance, in tissues of the colorectum, where it's thought to be very important, we can see that vitamin D levels have a direct effect on 1,25-dihydroxyvitamin D, which has an effect on the vitamin D binding, vitamin D receptor within the cell, where it binds with the vitamin A receptor, or the RXR receptor, which together is going to influence transcription of various proteins within the colon cells, which causes decreased proliferation, increased differentiation, etc., and therefore add increased cell death, programmed cell death, and therefore is going to influence, possibly, the turnover of gut cells and perhaps the rate of development of malignancies. But you need a certain amount of not only vitamin D, but also the vitamin A receptor. Okay? You also need calcium, which is important in it having a direct anti-proliferative effect on the cells within the colon. So we have a symbiotic relationship, if you like, of vitamin D, vitamin A, and calcium, particularly in the colon cells, which may play a role in controlling or preventing the development of carcinoma of the colon. Michael Holick, who has been a believer all his life, has written books on vitamin D. He has tabulated the possible effects of vitamin D in the human body. And we see here the calcium and phosphorus homeostasis and bone health, the musculoskeletal effects that may be important as far as vitamin D is concerned, influencing muscle mass, muscle strength, and perhaps balance, and which is particularly important in geriatric patients Patients are getting older, they lose their balance, they have muscle weakness, and they tend to fall. And if one can maintain muscle power, one may prevent the number of fractures that the elderly have. Then there are the immunomodulatory effects, where it may influence the development and the progression of multiple sclerosis. So we have type 1 diabetes, which may be influenced by vitamin D. We have psoriasis, where there's good evidence of the effect of particularly 1,25-dihydroxyvitamin D applied topically to individuals who have psoriasis. So on the skin itself, influencing the development of psoriasis in those individuals. And that's related to the influence of vitamin D on cell proliferation and differentiation. The role of vitamin D in autoimmune diseases such as rheumatoid arthritis, inflammatory bowel disease, and perhaps in periodontal disease. Then there's the cardiovascular effects and its effect on the renin-angiotensin mechanism, and possibly decreasing hypertension, decreasing type 2 diabetes, and reducing heart failure. And finally, the effect of vitamin D on growth and regulation of cells, where it has anti-proliferative effects, apoptotic effects, so it increases cell death, and may have an effect on a number of cancers, particularly those such as prostate, colon, breast, and perhaps lymphomas. And once again, that's a very impressive range of areas that vitamin D may be having an effect. And you can understand why one would like to see one is optimizing one's vitamin D status if vitamin D does have all these effects. So let's go back to the role of the classic role of vitamin D. And I've discussed this with you before. But about 90% of our vitamin D status is derived from sunlight. Not only in South Africa, but in many other countries. And in South Africa, it's even worse because there are very few natural foods that are vitamin D, that have adequate vitamin D levels. And as you as dietitians all know. So we're dependent then on sunlight, particularly, to maintain our vitamin D status. Diet contains very little because very few foods contain vitamin D. Breast milk is low in vitamin D generally, unless you supplement the mothers with very high levels of oral supplements of vitamin D. Cow's milk is low in vitamin D unless the cow's milk is fortified, as in infant formulae. And there are very few foods in South Africa that are vitamin D fortified. So if we're dependent on sunlight, what are the factors that are going to influence the amount of vitamin D that is formed in the skin? Well, the first most important is basically where one lives. And obviously, the closer to the equator, the more ultraviolet light that one is going to receive. If one moves away from the equator, if one gets to beyond about 40 degrees north or south of the equator, there are significant portions of the year when, even if the sun is shining, there is no UV light reaching the Earth for you to produce vitamin D. So if you live in Northern Hemisphere, for instance, and live in Boston, for about 4 or 5 months of the year, you're not going to form vitamin D, even if you were running around nude in the snow. Even if it was sunshine, you wouldn't get adequate vitamin D. Pollution is a problem, and it's been shown in India, for instance, that urban communities have lower vitamin D status than rural communities, partly not because the rural communities spend more time out in the fields, for instance, but it relates to the amount of atmospheric pollution that is present in the urban environment. Cloud cover is obviously important, and Cape Town's miserable. And I'll show you some data from Cape Town to show that it's a major issue in Cape Town. Clothing is an issue, and this is not only a cultural factor, but it's a dress code more than anything else. And the more coverage of the skin, the less vitamin D that you're going to form. And it's probably the major reason for the high prevalence of vitamin D deficiency in the Middle East, for instance. Melanin pigmentation does play a role. So the darker your skin pigmentation, the less vitamin D you form for a given amount of UV radiation. It doesn't stop the formation of vitamin D, it just reduces the amount that one produces. And it's said that you need probably 2 or 3 times the radiation dose of UV if you are darkly pigmented compared to a Caucasian with white light pigmentation. And then, of course, the duration of exposure. And then there's the other factor, which I haven't mentioned here, and that is the amount of 7-dehydrocholesterol within the skin, because your vitamin D is formed from 7-dehydrocholesterol. And there's evidence that as one gets older, so the amount of vitamin D you're able to form within the skin is diminished. So elderly people may need to spend longer in the sun than younger people because of this inability to convert adequately to vitamin D. Now, I think we all know the picture of vitamin D deficiency rickets in infants, which is one of the problem areas, that the infant before the child is walking is dependent on generally the mother's supply of vitamin D at the time of birth, and then on the breast milk content of vitamin D, and there's very little in breast milk, and therefore is dependent on UV exposure. But many babies don't go outside, aren't exposed to ultraviolet light, and therefore are at risk of developing vitamin D deficiency. The typical X-ray changes you see with the widening of the growth plates, the fraying of the growth plate, and the osteopenic looking bones that are related to vitamin D deficiency. Now, the mechanism for developing rickets in vitamin D deficiency is related to this. So if you become vitamin D deficient, one doesn't have adequate 25-hydroxyvitamin D, one doesn't therefore produce adequate amounts of 1,25-dihydroxyvitamin D, and therefore you don't have the 125 to normalize or to maintain calcium absorption. A reduction in calcium absorption leads to hypocalcemia, which may be marginal, but it's enough to produce an increase in parathyroid hormone, which has an effect both on bone and on the kidney. In the kidney, the hyperparathyroidism particularly increases phosphate reabsorption. And it is this hypophosphatemia that develops that is responsible for the development of rickets. If one doesn't drop one's serum phosphorus, you can prevent, to a certain extent, rickets development. And this has been shown in animal studies. In rats, you can make them vitamin D deficient and they will not develop rickets until one puts them on a low phosphorus containing diet. And once one puts them on a low phosphorus containing diet, they then develop the classic picture of rickets. The other effect of PTH is on bone, where it increases bone resorption, and therefore you get the development of thinning of the bones because of the increase in parathyroid hormone on bone resorption. So it's mainly hypophosphatemia that causes the development of rickets. Now here's a picture of, or a study that we did some years back, looking at the in vitro production of vitamin D. So we put vials of 7-dehydrocholesterol in the sun and then measured the amount of vitamin D that was formed in those vials that were left in the sun. And we did it on the vials were changed every hour, and we then calculated the amount of vitamin D that was produced per day. And we did this over a year period, both in Johannesburg and in Cape Town. And one can see here, from January through to December, the blue bars are Johannesburg. We can see that vitamin D production is relatively constant throughout the year in Johannesburg, saying that we get adequate UV radiation to form vitamin D adequately within Johannesburg and obviously Pretoria. What's going to influence our vitamin D status is going to be the temperature. because obviously the colder it gets in winter, the more clothes you wear, and therefore the less amount of skin one exposes to vitamin D. But there is enough ultraviolet light to produce vitamin D all times of the year in Johannesburg. In Cape Town, which are the green bars, one can see that during the winter months in Cape Town, there is very little vitamin D formation. Doesn't matter how much skin you expose, you're not going to form large amounts of vitamin D. So from about end of March, so it's through April, through to October basically, there is limited UV, or there's limited vitamin D formation. So, and that's probably an explanation why vitamin D deficiency was much more common in Cape Town in infants than it was in Johannesburg in the 1960s and 70s when I started training in pediatrics. We saw a lot of vitamin D deficiency, but they saw even more in Cape Town. And the reason for that is probably related to the amount of UV exposure that children were getting during the winter months. Now, how does this influence the amount that we get per day? So if you look at, this is in June, all right, so it's in winter. Here we see from 8 o'clock in the morning through to 5 o'clock in the evening. And we can see again that Johannesburg, the peak amount of vitamin D is formed, obviously, as one would expect, in midday, around midday. So from about 10 o'clock through to about 3 o'clock, we're producing reasonable amounts of vitamin D. But in Cape Town, poof, there's nothing. You get a little upsurge midday, but really very little else. Pointing to, again, the importance of latitude, and perhaps it may well be cloud cover that is important in controlling the amount of UV that reaches the Earth's atmosphere. Cape Town is at 32 degrees south. Joburg is 28. I think that's right. So in fact, we are well above the 40. Cape Town's not that far from where we are, but it's just sufficiently further south to produce these effects. Now, what about vitamin D deficiency per se? These are studies done from the birth to 20 cohort. This is this cohort of children we've been following since 1990. So we had 3,000 children born in 1990 that we've been following annually over the last 23 years. And this is when they were 10 years old. And we see here the mean vitamin D status, or 25-hydroxyvitamin D levels, in these children. Now, just bear with me. These values are in nanograms per mil, and I'm afraid there's confusion about how you measure vitamin D status in children and adults, the assays that one uses. They're either in the typical American units of nanograms per mil mass units, or they're in SI units. I'm afraid we've given them here in nanograms per mil. We'll discuss what is normal and what is not normal just now, but if we take 20 nanograms per mil as the upper limit of normal, or the average normal, then you can see the vast majority of children have totally normal levels of vitamin D in Johannesburg. And it doesn't matter whether it's autumn, winter, spring, or summer, they maintain those levels. That there is very little difference between black and white children, except during the summer months and then late summer, in other words, in autumn. And I do think, we don't know what the mechanism, why this is, but it's possibly related to skin coverage and the amount of swimming that one does if one is a Caucasian living in Johannesburg compared to our people living in Soweto. They don't swim that much. They don't have the opportunity to swim that much. So they don't spend lots of time lying around in the sun, as perhaps our white children do. So if we look at the degree of deficiency, it's not a problem. So in Johannesburg, it's not a problem. We don't have figures in the Cape. So Pretoria would be very similar, generally, we would assume. Just to highlight the importance of obesity as a factor that inhibits the amount of, or reduces the amount of vitamin D that one has circulating, the vitamin D status. Here we see BMI, the relationship between BMI in white children and in black children, females and males. And we can see it in both black and white females, girls, there is a relationship, an inverse relationship between BMI and vitamin D status. And that's been shown throughout the world that the more obese you are, the lower your vitamin D status. The mechanisms are not clearly understood. It's probably relating to the pooling of vitamin D within the adipose tissue. But whether that's true or not, I'm not sure. It's interesting that, in fact, the males, we don't see this. Now, it could be in the white males. We didn't have tremendous numbers with high BMIs. But in the black males, we have some obese black males, and yet they don't show that relationship. So whether there's a difference, I don't know. Now, let's talk about what is a normal level of vitamin D, or 25-hydroxyvitamin D, because 25-hydroxyvitamin D is what we measure to assess vitamin D status. It's the major circulating form of vitamin D, and it's what we measure because it's relatively stable. It has a half-life of about 3 weeks, so it's relatively stable in the serum. Several years back, the Institute of Medicine in the US actually appointed a panel to look at the newer data to assess whether there was a need to up what would be considered to be the vitamin D requirements of individuals throughout the life course. So they looked from infants right the way through to the elderly. And the panel produced its report in end of 2010, beginning of 2011. And this is basically their report. They reviewed the literature, and they came to the conclusion that they could not comment on the role of vitamin D in non-skeletal activities. The reason they couldn't comment on these non-classical actions of vitamin D was because there was just no data. There was data on associations. Yes, there are some associations, as was discussed earlier this morning by Mike Levine, on vitamin D and allergy, vitamin D and asthma. There are studies that are retrospective studies that have looked at the relationship between vitamin D status and these particular diseases. But there have been no controlled trials, or very few controlled trials, that have actually looked prospectively. I give vitamin D, what's the response over X number of years to the prevalence of asthma or diabetes or whatever it happens to be. So at the moment, the data is out. We really don't know what the effect is of vitamin D on many of these things like cancer, multiple myeloma, not multiple myeloma, multiple sclerosis, schizophrenia, diabetes, hypertension, etc., etc., etc. So they came to the conclusion that they were not prepared to provide any guidelines related to this. They did, however, say there was enough data to make reasonable guidelines as far as vitamin D requirements are concerned related to skeletal health. And this is what they came up with. They came up with an RDA and an estimated average requirement. And they said that the RDA, which met the requirements of almost all North American individuals, was 50 nanomoles per litre. Now, you as dietitians understand the terminology RDA. So this is when you cover the requirements of literally just about the whole population. But they say the average requirement was 40 nanomoles per litre. Now, again, please excuse the different units. Here the units are in nanomoles and in nanograms, so you can compare. But they said 40 nanomoles was the average requirement for vitamin D, 25-hydroxyvitamin D, and they said that the risk of deficiency increased once one gets below 30 nanomoles per liter. So we have increasing risk of deficiency, less than 12 nanograms per mil or 30 nanomoles per liter. We have increasing risk of inadequacy, whatever that means. And that's part of the problem. What do we mean by inadequacy? Insufficiency. Less than 40 nanomoles per liter, so with less that there are going to be increasing numbers of individuals who are not going to meet their vitamin D requirements as they fall below 40 nanomoles per liter. And then adequacy was considered to be greater than 50 nanomoles per liter or 20 nanograms per mil. And there were increasing risk of excess greater than 125 nanomoles or greater than 50 nanograms per mil. This is based on dietary requirements. Now, I say dietary requirements because they say we're not going to try and assess how much vitamin D one gets from skin synthesis. So we're going to assume that people do not get vitamin D through the skin, which I mean is garbage if you're in South Africa. But obviously it's true if you live in North America or in Canada, that for large parts of the year you don't get vitamin D. So you cannot be assured of maintaining your vitamin D status through sunlight alone. So they're saying what you need is a dietary intake of whatever it is to produce a level in the circulation of 12 nanograms per mil, 60 nanograms, 20 nanograms per mil, etc. So they're saying that we now are going to assess the RDA that is required, the oral intake that is required to produce these particular serum levels. And that is what they then did. But let's just point out first that the mean 25-hydroxyvitamin D status in the States, I mean, lots of people, if you read the literature, says, oh, everybody is vitamin D deficient. But if you look at the average, the mean 25-hydroxyvitamin D throughout the life course in the US, you see it is above the 50 nanomoles per liter level, therefore very adequate. The average is above it. You would expect the average to be sitting at 40 nanomoles per liter if it was to meet the requirements that would be mentioned by the Institute of Medicine. So using these figures, there's no evidence of no problem of public health vitamin D deficiency. There is a problem, however, if one takes the levels that perhaps Professor Kruger was mentioning, which is 75 nanomoles per liter. 75 is up here, and as you can see, the average values in the US don't reach those figures. And the vast majority of countries don't have populations with values in that range. So if you're going to use 75 picomoles per liter or nanomoles per liter, you're going to have to supplement the whole population, full stop. We'll come back to that. But these are the RDAs then that were produced by the Institute of Medicine. First for calcium and then for vitamin D. And I think just look at the vitamin D levels. They're saying that the total amount of vitamin D you require to maintain your vitamin D status without any sunlight is, in the first year, 400 or 600 international units, depending whether you use an EAR or RDA, going down and remaining relatively constant throughout childhood and adulthood until you get to the elderly. And in the elderly, they have pushed up the RDA to 800 international units per liter. Okay? The upper limit of values that one can give, the upper range, was given here. So it's about 4,000 international units. They feel that it's safe to provide that on a regular basis. Now, they assumed, and I'm just going to go through this again because I think it is very important, they assumed that there was no or very little dermal synthesis of vitamin D. Okay? So if you do spend time in the sun, you don't need the the oral vitamin D. The recommendations are for total intake and we're not talking about supplementation. Again, that's important. We're not talking about supplements here. We're talking about total intake. And it pertains to skeletal and mineral health only, and nothing to do with whether it's going to reduce your cancer, your diabetes, or whatever it's to be. It also assumes an adequate calcium intake, because it's obviously clear that if you have a high calcium intake, the amount of vitamin D you require to absorb that calcium is going to be less than if you have a low calcium intake and you've got to maximally absorb calcium from the gut. So there is this relationship between calcium and vitamin D. And they are assuming here that everybody's getting an adequate calcium intake. The recommendations are also for the maintenance of an adequate vitamin D status and not to treat disease. Okay, again, that's important. We're talking about normal individuals here. And the recommendations are based on the lifestyles and diets of North Americans, not on black South Africans or Chinese in China or Koreans in Korea. We're talking about North Americans. That includes Canada and the USA. Now, having said that, this is where the confusion comes in, because no sooner had the Institute of Medicine produced this report than the US Endocrine Society, which is the Society of Endocrinologists in the US, produces its report, which again is written by Michael Holick, who is a believer. Okay? I have to say that because I think it does influence. It does, yeah, you have rose-colored tinted spectacles. And they produced so-called norms, and they came up with different values, which is what Professor Kruger was mentioning. Vitamin D deficiency, less than 30 nanomoles per litre. Now, the IOM, the Institute of Medicine, said less than 30. So, significant difference. They say that you need 75 nanomoles per litre to be sufficient. The IOM said 50 to be totally deficient, to cover the vast majority of the population. So we have a problem. If I'm a laboratory, I'm going to use the higher values because I want everybody to have their vitamin D status measured because they're not going to charge them for it. And if I'm a supplement purveyor, I'm also going to say, hey, these are lovely, because you're going to have to take supplements to get your vitamin D status into these levels. And therefore we have to question, I think one has to question the reality of the recommendations being made here. That public health medicine is dependent on populations. Are we saying that we're going to have to fortify or provide supplements for literally 95% of the population, which is what one would have to do if one went that way? Not only in South Africa, but in Europe and America and all the other countries, because we don't have levels anywhere near that in the vast majority of countries. When the Endocrine Society was asked how they could come up with values that are very different from the IOM, the Institute of Medicine values, they said, well, this is for people at risk. So it's not necessarily healthy individuals, it's people that are more at risk of vitamin D problems than others. They're dealing with sick individuals, they say, and therefore we have factored in that in producing these values. And I think that may be true. So I don't think we should, I'm not saying, look, this is inappropriate, but I think if you're giving advice to normal individuals, I would recommend that you use the Institute of Medicine values, which is a much more conservative, I think a much more sane level than the values being produced by the Institute, by the Endocrine Society. And part of the reason for the Endocrine Society's belief is, in fact, this data that is produced by Heaney, which he says shows that As you increase your vitamin D status, your 25-hydroxyvitamin D, that intestinal absorption increases progressively until you get to about 70 or 75 nanomoles per litre. Now, the problem with this study is that it's not a single study, it's multiple studies that have been put together. And there are major issues related around a number of the studies that were used to draw up this data. But it looks very impressive. It's a very nice slope and then plateaus. However, there's a study, for instance, that comes from Australia, from NEED, where they looked at calcium absorption in a group of individuals who were attending an osteoporosis clinic in their, I forget now which town they are, which city they're in. I think it's Melbourne, in fact. No, Adelaide. They were in Adelaide. And they looked at their 1,25-dihydroxyvitamin D levels compared with the 25-hydroxyvitamin D levels, and they looked at calcium absorption compared to the 25-hydroxyvitamin D levels. And they showed that calcium absorption only started to fall when the vitamin D status, or the 25-hydroxyvitamin D levels, were less than 15 or 17 nanomoles per litre, so very low. Okay? And likewise, the 1,25-dihydroxyvitamin D levels only fell once the 25-hydroxyvitamin D levels fell below about 17 or 18. So they are suggesting that, in fact, vitamin D for calcium homeostasis purposes remains relatively good until you get into the really deficient range of less than 15, perhaps, nanomoles per litre. Now, just some other issues. Does vitamin D receptor, or does vitamin D play a role in the fetus? Do we need vitamin D for normal bone metabolism in the fetus, for normal development of the fetus? And the answer is no. We don't need vitamin D for the normal fetal development or normal bone development. You can produce mice and rats that are knockout animals that don't have the vitamin D receptor, and you do not disturb fetal mineral metabolism, you don't influence placental calcium transfer, and you don't disturb the developmental mineralization of endochondral calcification or mineralization of the skeleton. So the fetus does not require vitamin D. If one removes the enzyme necessary to convert 25 to 1,25-dihydroxyvitamin D, the manifestations of vitamin D deficiency, which will develop because you can't convert 25 to the active metabolite, only develops after weaning in animals. And there is a similar genetic disease in children called vitamin D dependency rickets type 1, where they have an absence of the 1-alpha hydroxylase enzyme and therefore can't produce 1,25-dihydroxyvitamin D. In those children, they are born normal. They only start manifesting their picture of rickets and hypocalcemia around 6 months of age. So again, showing that normal fetal development appears to be, let's say fetal development appears to be normal without having the enzyme necessary to convert 25 to 125. And here we see, in fact, the morphology in a mouse with the vitamin D receptor being intact and the mouse without the vitamin D receptor. And here we're looking at skeletal mineralization, and they are the same. If we look at the long bones, this is the growth plate of fetal mice with and without the vitamin D receptor, and one can see no difference between the two. So again, just highlighting the lack of the role of vitamin D in normal fetal development. What are the implications, therefore, for the human fetal development and vitamin D requirements during pregnancy? We make a lot of noise about we must make sure that the mother has an adequate vitamin D status. Well, there is some evidence that vitamin D deficient mothers, or let's say infants born to mothers who are vitamin D deficient, have a slightly higher prevalence of neonatal hypocalcemia. that very rarely one can actually get congenital rickets, in other words, rickets developing within the first 6 weeks of life. But that is only seen if the mother herself has severe vitamin D deficiency and has severe disturbances in calcium homeostasis. There is an increased instance of infantile rickets, but it doesn't occur in the first 6 weeks of life or 6 months of life. It occurs after that, that there is this relationship between maternal vitamin D deficiency and infant vitamin D deficiency. But this occurs as the infant gets older and properly relates to why that the infant is being exposed to the same environment as the mother who is vitamin D deficient. And also there's going to be very little vitamin D in the breast milk. There's possibly, and this is really question mark, poorer intrauterine growth. But it's one study, and that's all. There is an increased risk of type 1 diabetes, possibly, but again, there are no good trials to show that if we look at it prospectively, that we can actually reduce type 1 diabetes. There is also an increased risk of asthma, possibly, but again, as was mentioned this morning, there is no good evidence prospectively that this is true. And possibly there's poorer bone mass in later childhood. But this study, in fact, has been refuted by the authors that actually produced this data. They've looked at 10-year-old children rather than 9-year-old children and have not been able to find evidence of bone mass influence dependent on the vitamin D status of infants. So if we knock out the intestinal vitamin D, what we find is that the calcium homeostasis is maintained in mice and growth is maintained in mice by increasing the vitamin D status of these individuals, by increasing the production of 1,25-dihydroxyvitamin D. And I'm not going to go into these. That's what we'll move on. Oh, one I would like to show you. There is importance of vitamin D in the immune system. Okay? And we've had the discussion about the role of the immune system in asthma and the balance between helper cells, type 1, and Th2 cells this morning. Niels Finsen from Denmark got the Nobel Prize for Medicine and Physiology in 1903 for his treatment of TB, skin TB, using, it was actually arc lights, but ultraviolet light, basically. And here's one such an example. Here we see lupus, what's known as lupus vulgaris, which is actually TB of the skin. And therapy with nothing else but ultraviolet light or arc lights produced a very dramatic response. And you see here individuals with skin TB getting therapy from an arc light, which is up here, being channeled down what look like telescopes onto the face of individuals who have the TB of the skin. And the effect of that was that prior to chemotherapeutic agents for the management of TB, and this is in the US, that hospitals were built, particularly TB hospitals were built, so that you could push patients outside to get their ultraviolet light therapy. And we've forgotten this, I think. We think that our chemotherapeutic agents are wonderful and that they treat TB, but perhaps they don't. And here we see children, for instance, sitting around an arc light, producing ultraviolet light, wearing goggles because they don't want to burn their retina, but also being treated for TB. And that's all they had in those days. And if you lived in Switzerland or you had lots of money, you would go and sit on the Mont Blanc or one of the high mountains in Switzerland and go and lie in the sun to get your treatment for TB. So there is some evidence that clinically vitamin D does play a role in immunity. And there's good evidence now to show that it's important. What the role of vitamin D is in normal individuals with TB, we don't know. We've done some studies in Botswanan children with and without TB, and we found no difference in vitamin D status. So, who knows? The issue of breast cancer and UVB exposure, this is in the US. We can see that the maximum amount of breast cancer is in the northeast corner of the US, and it reduces as you go down towards the Mexican border. This also relates to the amount of UV exposure there is. But these are associations and not good evidence, correlations of good evidence of the effect of ultraviolet light. Similarly, prostate cancer, more prevalent in the north than in the south of the US. And similarly, colon cancer, again, more prevalent in the northeast than in the south. And the comments from a recent paper was that chronic sun exposure properly decreases the risk of colorectal, breast and prostate cancer and non-Hodgkin's lymphoma. In colorectal and breast cancer, the effect is likely to be through vitamin D, but not in prostate cancer or non-Hodgkin's lymphomas. It's related to something else that is related to ultraviolet light exposure. And that vitamin D may also have a positive influence in the mortality of some cancers. But again, we don't know at what levels, and that's part of the problem. So now, all you dietitians are well aware of the U-shaped curve that one has with most nutrients, that down this way as your intake decreases, so you run the risk of deficiency. Up here, you run the risk of excess. And that's the balance that one is walking when one is talking about vitamin D. If you give too much, you're going to increase, perhaps, calcium excretion in the urine and renal stones. If you give too little, you're going to develop osteoporosis, perhaps. And the conclusions then, and this is from a recent article by Clifford Rosen, is that the relationship between vitamin D and the risk of chronic disorders is controversial. If we leap to conclusions, we often do more harm than good, and he's suggesting be conservative at this stage. We have conflicting observational data and absence of data from controlled trials, and that's part of the problem. We need authoritative evidence-based cut-offs agreed by all, and that's where we stand at the moment. So I would like to suggest that we should be cautious. Don't recommend large doses of vitamin D to your patients. We don't have good evidence for it. It's very exciting. I think, I'm not saying we won't have the data. The data will come, and we'll be able to make up our mind. But at this current stage, we don't have the data to be able to say, yes, this is what we should be doing. So rather act conservatively, rather give relatively small doses, and advise your patients conservatively. Thanks very much indeed.